So now let's go back to humanity. And because after all, we still run on coffee, not on code. So it's my great pleasure to introduce this morning's keynote speaker, Peter Embi. Yes, he is absolutely a human. And yes, I did check that with my AI assistant. So Dr. Peter Embi is an internationally recognized physician scientist and thought leader in the application of AI to healthcare. He is professor of biomedical informatics and medicine at Vanderbilt University. He serves as the chair of the Department of Biomedical Informatics and the CDO Vice President for Research and Innovation. Before Vanderbilt, he had many other distinguished appointments. He was the president and CEO of the Reagan Street Institute, the VP for Learning Health System at IU Health. In addition, he is the founder of the field Clinical Research Informatics and created and served as the nation's first Chief Research Informatics Officer at the Ohio State University. So Peter Embi is a member of the National Academy of Medicine and a fellow of American College of Physicians, American College of Medical Informatics, American College of Rheumatology, and International Association for Health Sciences Informatics. He is the past president and chair of the board for American Medical Informatics Association and the current president for the American College of Medical Informatics. Dr. Embi received his MD from the University of South Florida, master's degree in medical informatics from OHSU, and a bachelor degree of science from the University of Florida. So please join me in welcoming to the stage Dr. Peter Embi.
Thank you so much for that kind introduction. It's so wonderful to be with you all today. Really, I've been saying this is just such an amazing venue, and congratulations to everyone here. I had the privilege of also speaking at the commencement yesterday of the School of Informatics, and got to celebrate the students who were graduating. And I also expressed that not only is this a professional privilege and honor to be here, but it's also a personal one, because the first time I ever stepped on this campus was actually when my father was being treated at MD Anderson for rare leukemia. And I'm very happy to say he's still with us, thanks to the incredible work and discovery and efforts. So thank you. Thank you. Everything that you all do is incredibly important, and I think it's really critical that we keep an eye on that. So with that, I'm going to talk a little bit about what Jaji asked me to get into here. So I'm going to give you a relatively quick tour of some of the things we're doing at Vanderbilt, but I'm going to start with a case because it's often helpful to sort of ground us. And so the case I'm going to start with is a case that happened about 7.5 years ago, and the case was me. So this is me about to go into the operating room. I am not feeling nearly as good as I am pretending to be in that picture. I'm about to go in for a pretty major operation. About 2 months before that, I started to have extremely severe spells. I actually had lots of symptoms prior to that for many, many years, but I started to get these severe spells that would come on acutely with headache, profuse sweating, pallor, palpitations, panic, anxiety, severe hypertension. I didn't appreciate that's what was happening, but I did in fact have severe hypertension. And I'm sure some of the physicians in the room have probably already made the diagnosis, but it was a challenging one, as it often is for a lot of people. But the first time I had my severe spell, and I didn't know what was happening. I thought I was having a panic attack. I wasn't sure. Like a good doctor, I did not go to the emergency room, which was a mistake. And then 5 days later, I was in Boston, and I was going to be serving on a panel, not unlike the one we're here to do today. And I got to my hotel room, I laid down, and I had another one of these severe spells. Thankfully, my girlfriend was with me at the time and said, "We're going to the emergency room." And I said, "You're right." And so we went to the emergency room. I won't name the place, but it's one of the man's greatest hospitals. And I was there for about 8 hours, and they did what you should do when somebody walks in with the worst headache of their life, and they ruled me out first for a bleed in my head, which I did not have. And then they gave me lots of Demerol for my pain, and they gave me some clonidine for my severe hypertension. I came in with a systolic of 220 and severe tachycardia. And 7 hours, 8 hours later, they discharged me with atypical migraine and hypertension. I continued to feel quite sick, went back to Indiana, where I was at the time, saw a neurologist, and the neurologist saw me and after a few more episodes and said, you know, the nature of this headache, it just doesn't fit with migraine. I think it might be occipital neuralgia. I'm going to give you some injections in the back of your head and you should feel better right away. And I said, great, let's do that. So they gave me some injections. I went back to my institute, sat down for grand rounds. Immediately another spell began. So I went back to my office, tried to keep my assistant from calling 911 because I looked like I should be calling 911. And while I was sitting there suffering with, at that time was about my 5th or 6th spell, I thought, okay, Peter, what's going on? Like, work the problem. You're an internist. I'm a rheumatologist, actually. Maybe I'm having panic attacks. Maybe this is psych. That would be fine. I'll go see a psychiatrist. Let's take care of it that way. And then I realized, no, this is something else. And I thought, you know, what's the differential here? And thankfully, because I think that way, it just hit me. I said diaphoresis, hypertension, headache, and that's the classic triad for a rare condition called pheochromocytoma. So I called the neurologist and said, I know this is going to sound crazy, but I think I have a pheochromocytoma. And she said, well, probably not, but stranger things have happened. Let's check your blood work. And my blood work came back, and my medinephrine levels, my adrenaline levels, were 30 times normal. So I was walking around at baseline with 30 times the normal amount of adrenaline all the time. And then my spells would result in, who knows, 300 times. And about 50% of people who get this condition die from it before it's ever diagnosed. It's a challenging thing to diagnose. It's a relatively rare condition. About somewhere between 2 and 5 in a million people get it. And therefore it's challenging. But there was no question once the labs came back that that's what I had. And then, because of who I am, I was able to accelerate, as many of us know how to do, my workup. I was able to get in to see an endocrinologist very quickly. I was able to get a CAT scan MRI. I was able to find a good surgeon who actually does these. Only about 1,000 operations in the US every year for this condition. You want somebody who does more than a few of them to do the operation, especially when you have one as large as mine. Mine was the size of a grapefruit. Your adrenal gland should be about the size of a walnut. Mine on the right was the size of a grapefruit. By the time it gets that big, you're not doing well. And my point in all of this is that because of who I am, and I'm standing here in front of you, and that's not right, and that's not necessary. We can do better. You shouldn't have to be a physician who's knowledgeable and well-connected and knows how to access the system in order to be able to get a diagnosis, in order to be able to get good care, in order to be able to survive these things. And we can do better. And that's what we're all here to work on. In my case, and I apologize, I know there are non-clinicians in the room and some of you just had breakfast, so my apologies. But this is my tumor selfie. Not really a selfie, my surgeon took it. But this is my tumor that was taken out of me. And as soon as it came out, and I survived the operation, which has about a 2 to 3% mortality rate on the table, I woke up and I had a few thoughts. One, first, I was very grateful to be alive. My second thought was that I realized what I just shared with you, which is that I was very fortunate and that others are not so fortunate. And that we need to do better. And I realized there were many ways in which my diagnosis and my care and the care of others could be improved through informatics and as part of that AI solutions. And we should work on that. So I was only reinvigorated to continue to learn and do better. So what I want to share with you is a series of lessons and then use that as anchor points to really talk a little bit about a few things, to talk about AI-driven learning health systems and what we're doing in AI at Vanderbilt University Medical Center, where I lead the AI Center and our governance process and the informatics group, and also what we're doing in terms of collaboration, because we all have to work on this together, which is why, again, I'm so happy to be here with you all at this fantastic meeting that's brought so many people together from so many different sectors. First lesson is that diagnostic errors abound. We know this. It's a problem not only in rare diseases, but in more common ones. People often don't get diagnosed as quickly as we would like them to. Sometimes there are errors, and bad things happen when that happens. What we teach medical students is this phrase: if you hear hoofbeats, think horses, not zebras. And that's a good way to teach, because so many things present similarly, that if you're walking down the street here in Houston and you hear hoofbeats behind you, don't expect to turn around and see a zebra. That's probably foolish, right? If you're in the Serengeti, it's a different story, but here, it's going to be a horse. And so that's a good lesson to learn. But there are zebras in the world, and rare diseases are rare, but people with rare diseases are common. And we actually have a lot of that, of course, at places like this and all of your campuses, because that's where people come. So consider, especially those of you who interact with medical students and nurses, to maybe say, when you hear hoofbeats, expect horses, but consider zebras. We have been working in informatics for quite a long time on diagnostic decision support systems. This goes back to well before AI, or I will say maybe the rudimentary early versions of AI, where we really wanted to try to figure out how we could create systems that would actually help. Ironically, one of the earliest systems that's actually listed there, DXplain, was actually developed at the very institution where my diagnosis was missed. And if that system had actually been integrated into care, it would have produced a differential diagnosis, and almost certainly my condition would have been right at the top, because I was a very classic presentation of a rare disease. But despite a lot of work to develop these systems, we really haven't gone the final mile of really incorporating them into practice. And in a lot of cases, we still have work to do to develop the systems, so not to say there isn't a lot of work to be done there. But at the end of the day, we can build all the fantastic AI tools we want. If we don't actually get them to the point of care and in the hands of the right person at the right time to make the right decision, then we're not going to actually see the benefit from it, and that's really important. There's been a lot of work on this. And we need to do more of it. But the idea that we need to be working on diagnostic error is a really big one. For what it's worth, when you plugged my top 3 sort of presentation features into Google at the time, there was my diagnosis at the top. I joked when I finally called the emergency room docs back and gave them a little feedback after I was cured, and said, hey, by the way, you guys missed this. And after I reassured them that I wasn't interested in suing them, I said, look, I just want you guys to understand, first of all, you saw a pheochromocytoma. That's cool. You should tell your friends. Also, I'd really like you to think, and the resident asked me the right question and said, what could we have done differently? And I said, look, it would have been heroic and extraordinary for an emergency room doc in a setting like that, as busy as they are, to make a diagnosis of one of the most rare conditions that we see. Your mistake was not missing the diagnosis. Your mistake was sending me home, because I still had severe hypertension, severe tachycardia, all of the sort of end organ dysfunction that I came in with, and you should have admitted me. If you had admitted me, almost certainly somebody would have made the diagnosis. So hindsight, we all make mistakes. I've made mistakes. It's not a criticism so much as an opportunity. But the joke was, if a medical student had seen me, they probably would have made the diagnosis like that, because it had not. They don't know how prevalent things are. Like, that's something you have to learn with experience, right? And in fact, I think if they had seen me and said, this looks like a pheochromocytoma, I'm pretty sure the attending would have said, that's adorable. We're not going to diagnose that today. Anyway, lesson number 2: we do not have a learning health system. We want one. We strive for that. You all are in a really enviable position with all the connections you have across this incredible system to interconnect, and all the work you're doing around data integration and system integration and the like, to really enable a learning health system across the UT system, for example, et cetera. But we don't have that yet. We don't even have that within our local systems to the degree we want. There are examples of pieces of that, but we need it. Having said that, we do have ways we learn, and one of the ways we learn is when we make mistakes. I think we can all agree that's a terrible way to learn. So we don't want to wait for catastrophes and bad things to happen. We want to be proactive. We want to use our data and our technology and our capabilities to systematically learn. Now, doing that takes thought about how would you instrument a system to actually be a learning health system. And that's one of the things I would ask you to think with me about. Certainly something I spend a lot of time thinking about, and there are ways to do that. I think this is an opportunity to do that. There's definitions I won't go into in the interest of time of what is a learning health system, but the Institute of Medicine, now the National Academy of Medicine, has written about this. We have work, for instance, from my colleague Chuck Friedman in Michigan, who's presented on this quite nicely in terms of a sort of problem of interest-centric approach, where really what we want is this virtuous cycle where we take the experiences from care and the data that flow out of that, we use that to generate evidence, and then we sort of feed that back and continue to have a virtuous cycle. This is a diagram that I could have taken from anywhere in the literature since 1992 of the idealized approach to what we call evidence-based medicine or evidence-based practice. For those of you who may not know, this was controversial when it was first proposed, right? The idea that we should do evidence-based medicine was first proposed in the early 90s was surprisingly controversial. Now we accept this as the ideal, and here's the approach, right? You generate evidence from research, you synthesize the evidence, you develop evidence-based policies, you apply the policies, and then you take into account the patient's circumstances, the patient's wishes, and the evidence, and you make a decision. Nothing wrong with this. This is great. We should be doing more of it, and there are ways that AI and informatics capabilities can help us do this better. But the main reason I'm showing you this diagram is not that. It's to show you that whether we realize it or not, the unidirectional relationship between what we call research, you could call that learning, you could call that discovery, you could call that improvement, but research, the relationship between research and practice is unidirectional. We should take evidence from research and apply it to practice. And we've instrumented our system, we've built our technologies, we've built our payment structures and our incentives with that in mind. So spending time learning, doing research, continuing to improve at the point of care to actually create a virtuous cycle that feeds back is not something we pay for. It's not something we therefore spend as much time on, and it is something that is something of an afterthought, and that's a problem. So one of the things that my colleague Philip Payne and I wrote about a few years ago, and there's been other sort of thought on this as well, is basically the same sort of concept, which is we need to be thinking about evidence-generating medicine or evidence-generating practice and all the different things that need to happen in order to enable that, even as we are thinking about evidence-based practice. So rather than this unidirectionality, we need a virtuous cycle. And what does it recognize? It recognizes that clinical care activities are not entirely distinct from research activities, that we should be considering evidence generation when we practice so that we can advance science and care. In fact, there's a lot of these activities ongoing, especially at our academic centers, and that's where we need to be leading and showing how you can do this in ways that are efficient and effective and actually improve the care of people tomorrow and the day after that. And it's really critical to the evidence cycle. And there are multiple enabling factors and stakeholders, and I'll refer you to the paper for more details on that. But the idea is this learning cycle. That's the simple version. So even back to my case, and by the way, this is a good moment to say I'm not advocating that we reorganize the healthcare system to diagnose rare diseases only, right? That's not the idea. It's more illustrative of there's lots of ways in which we need to improve for all conditions. But even in the simplest case of learning, which is, what did I miss? It's not scalable for me to call and say, and, they took my call, but they're not going to take most people's call. So what we really need is a system that enables us to learn. And we have to decide to use it for that. When I was at Indiana, one of my roles, I led the Regenstrief Institute, and we interacted with a lot of our health systems locally, and I was also the vice president for learning health systems at IU Health. And the reason I took on that role was to actually integrate the academy and the operations and bring people together. And one of the first things we did was we said, what are our goals? What are we really trying to accomplish as a learning health system? And I made sure that the people who were actually divining and deciding what those goals were first and foremost the operators, the people who were actually running the hospitals, running the systems, because if they didn't lead that and they didn't buy into what those goals were, the academics all day long could come up with theories and ideas, and we love to do that. But that's not really going to have impact and matter if it's not also bought into by and really owned by the operators of the system. And we need to also then figure out, how do we combine the expertise across these groups? So what we came up with, just to share, and again, there's more you could read about this, are these goals. We want to, first of all, learn from every patient, right? Not literally, but figuratively. We want to overcome the fragmentation of one of my favorite phrases. We have, I'm sure you don't have them here, but we have many silos of excellence. And they're excellent, but the silo part is the problem, right? So integration. When we do things that work, we want to know they work sufficiently that we can then say, okay, we need to scale that. And we need to scale that across the enterprise. We often do things, we do pilots, we do projects, we do PDSA cycles, quality improvement, but we don't always come out of that knowing enough to say we should scale that. Or, you know what, that didn't work. We should stop doing that. Those are pieces of evidence we wanted to get. We want to improve care and satisfaction across all stakeholders. We wanted to improve our processes, yes, our efficiency, but also our outcomes and our costs, basically bending the value curve and doing that in an equitable manner. We wanted to improve our processes, we wanted to accelerate discoveries and translation of those discoveries into practice. And again, that came from the operators. And then we want to disseminate that. We do want to disseminate that. Everyone wants to do that. If we figured something out that could benefit others, that's part of our task. And then we want to use the learning health system as a differentiator to say, look, you want to come get care here because we are a learning health system. And that means we're continuing to improve, and this is where you're going to get the best care. Oh, I'll cycle through this. Lesson number 3, and I'm breezing through this because I know we have an agenda. Lesson number 3, we traffic in clinical data. And thankfully, because of all the work that's happened over the last couple of decades, we are doing a pretty good job these days of actually bringing our data together, and we could still do better. But that represents a relatively small sliver of the data that we really need in order to really understand someone's health. So I will argue that during those 2 months between when I first presented to the emergency room and when I ultimately had my definitive procedure to cure me of my pheochromocytoma, my medical record was a pretty good representation of my health during that period of time. Before and since, it's not the best representation of my health. If you really want to know about my health, you need to know how many steps I'm taking, what I'm eating, the air I'm breathing, how much crime is in my neighborhood, all kinds of other things, and my genetics and other factors. And that's really the point, right, is if we really want to get a handle on all this, we need to bring this together. And case in point, when I had my diagnosis, because I'm a nerd, I interrogated my Apple Watch, which at the time did not yet have the feature that it now has, which it'll tell you if you have resting tachycardia now. But back then it didn't, but I could interrogate it. I downloaded all the data, and I had, you can imagine, hundreds of spreadsheet pages of all of my heart rate. Every single day for the year prior to my diagnosis, I had at least three episodes of resting tachycardia. Okay, that was my adrenaline. I didn't appreciate that. I just thought, oh, I have a benign flutter or whatever. But because of course you explain things away. But here's the other point. If I had taken those data points and I had put that in front of my clinician, I know what I would have said. No, thank you. I don't know what to do with this. Not sure what to make of it. Now, maybe not, right? There was meaning in that. In my case, we now know there was meaning in that. But here's the thing. What does that mean? What are the normal ranges? What is standard? We got to figure that out. And that's the role of informatics. That's the role of a lot of us in terms of really determining, like we do with labs, what is normal range, what does it mean, and how do we actually incorporate all these data? So there's a lot of work to be done, not just bringing the data together, but then really understanding the meaning of it. And that's a lot of what we do in informatics. We combine across the phenome, the genome, and what we call the exposome to really understand how we can take all these different data sources, these multimodal data, and we can pull them together, and we can also have methodologies that we bring to actually do that work and then make sense of it and use it. And this is also a good moment to say, this is from another paper I wrote with some colleagues recently after COVID, where we really talked about the intersection point between what we do in informatics programs and what we do in health IT. And there's incredible expertise and need to actually work across those teams. And the places that do that well see so much more benefit. because the operators who really run health IT understand what it really takes to make that work in the real world, and the informaticians are thinking about other aspects that are very complementary in terms of validation, verification, and other aspects of innovation, and the complementarity there is really critical. So we think that's a really important piece to succeeding. Lesson number 4, we want to create an AI-enabled learning health system. And this is not just a technical activity. I said this to the graduates yesterday. Yes, we need to be very, very good technically, and we got a lot of expertise there, which is great. But anybody who's been doing this long enough knows that successful informatics and AI projects succeed or fail, usually not because of the technology, but because of how it's deployed, how it's used, and whether or not it's actually effective that way. And that is a socio-organizational exercise as much as it is a technical one, so a socio-technical challenge. There are many variables and considerations, not just the technical, but fiscal and administrative, the alignment of incentives, et cetera. And then there's multiple levels at which we need to deal with that, with policy, at the system, and even at the individual level. So let's talk a little bit about AI. Don't need to belabor for this group that AI is here, and it is poised to transform healthcare. This is not hype. Yes, there's some hype, but it's real. We've been working on it for a while, and boy, it's here to stay. And if anybody thinks this isn't going to transform what we do, then you're mistaken. I'll just put it very clearly. What are we doing at Vanderbilt? We've been doing a lot of work in this area for quite a long time. So on the left-hand side, you see just some examples of major NIH initiatives and others that I know some of you are also involved in here in Texas, related to really advancing our knowledge and expertise and capabilities in AI. And that's really important that we continue to do that research, and that's being funded. And we have a lot of groups we work with in the National Academy and others. And we have organizations like, I know Brian Anderson from CHI is here doing exceptional work, really thinking about how do we really govern and oversee and have standards and capabilities to make sure that we are doing this responsibly. We have the TRAIN network and others that are established to do that as well, and we'll talk more about that later today. When we think about this at Vanderbilt, and I think this is probably a lesson that I wanted to share here too, we think of it in a couple of ways, and this led to the creation of the center that I lead there. One is that we have incredible strength foundationally, and that's really important. Where we have exceptional expertise in biostatistics and the data sciences more broadly, and informatics, and we're doing really good science. But we also are very good at implementation, and both of those things are really important. If you just have one and not the other, you're not going to succeed. And so what we really see as the transformative opportunity is to really integrate those. And if there's a theme in everything I've done throughout my career, it's about that intersection point, building those bridges, bringing people together, because I really believe in that. You get much further and much more successful when you actually bring people across disciplines and across silos together. And so we created what we call the Advanced Center, AI Discovery and Vigilance. I'll talk a little bit more about vigilance in a moment, to accelerate innovations in clinical excellence. The diagram there shows that it's not just an academic center. Yes, we care about research, we continue to do research, but practice is very important, as is dissemination, whether that's dissemination commercially or in the traditional academic ways or through collaborations. And then what we do is we wrap that with connections, deliberate connections to other parts of the enterprise that relate to making sure we take advantage of all the expertise that we have across our environment, operational excellence, infrastructure, and we've been doing a lot of work to build that out, and governance. I'll breeze through this, but we had various goals that we laid out for this. So we want to accelerate adoption. We want to increase our access to expertise across the environment. We want to strengthen our ability and capabilities in terms of what we can do. We want to enable the people with good, solid infrastructure that is shared, and we want to educate. We want to make sure that gets incorporated into all of our activities going forward. There we go. We want to continue to grow our not only internally, but our partnerships with industry, because we really can't do this alone. We all have to work on this together. And we want to also ensure that these systems are effective, and that they are safe, and that they are being used ethically. And then we want to ultimately transform practice. Let me speak for a moment about governance, and I'm happy to drill down into any more of these during breaks, but within the governance apparatus at Vanderbilt, which I co-lead, we actually have a very robust governance process, and it's really important. I'm sure you guys have some versions of this as well. We are tracking what's happening within our state, but also federally, to know how we need to respond to that. We are rewriting and rewriting our policies accordingly. We're working on really addressing the issue of how do we know what to procure and how do we know that it's working. And we've come to talk about this as internal and external procurement. Some things we build, that's internally procured. Some things we get from third parties. Either way, we look at them as procuring, because once we put it into practice, we need to govern those things in a very similar way. Oh. And then we have an inventory. Right now, we've got up to 200 just clinical algorithms running across our One Health system. And then we develop monitoring capabilities. So I'm going to talk about that for just another couple of minutes. Why do we need to monitor AI? And this is something that is quite nascent, and we need to do more work on. So as AI is being used more and more, we know that it has incredible potential, but we also know that there's a lot of potential for harm. And some of that is because the very data that we train these models on just inherit the biases of our society. That's just the way it works. This is not magic. We have to train these with data, and the data have flaws. They aren't fully representative of everyone that comes through our door. And so if we train models, and if we make assumptions about those models that doesn't take into account the fact that it isn't necessarily representative of everyone, then guess what? The models are going to be biased. And we see evidence of that when we look for it. But we need to be looking for that much more systematically, not just finding those things serendipitously. Why? Because again, bias in the data, both the known and the unknown. We need to be cautious about assuming generalizability. A lot of these systems really aren't. You know, they might perform extremely well at Vanderbilt. They were trained and validated, and we think they're great. But if we take and hand that over to an institution here in Houston, it may not perform the same way. You have different workflows, you have different capabilities, and you have different populations. So that needs to be tested and monitored. If you can expect anything, it's the unexpected. We have to do this to promote trust across the entire system. We need new systems to do that. And that's really essential for safe, efficient, effective, and equitable care. So I wrote about this about almost 6 years ago now. I was sitting on a panel and somebody said, what are you most concerned about with the deployment of these AI technologies? I said, what I'm most concerned about is we don't really have an apparatus, a learning health system to really monitor these things, and I think we need that. Much like we have approaches that we use for pharmacovigilance, we need something like algorithmovigilance. And so we've been building a platform to work on that with the idea of creating this learning cycle where we don't just stop at deployment, but we continue to monitor and change. And so we look at this from a quadrant perspective. Again, in the interest of time, I won't go through this in detail, but there's preventive approaches that we can build into the AI tools themselves with advanced computer science methods that are evolving. We need technical oversight to know where there's interdependencies with other systems. So if something that is really key to a particular AI system working is changed or updated, then it could break the AI solution. So it's good to proactively and preemptively identify that. We need the data-driven oversight, which I'll show you in a moment with dashboards. And then sometimes, despite our best efforts, we just need end-user reporting to tell us something's gone wrong. We have a system then that we created that we call VAMOS. I'm Cuban, so I like a good Spanish acronym. So VAMOS had the right feeling. The Vanderbilt Algorithm of Vigilance Monitoring and Operations System. Essentially, think of it as kind of an air traffic control dashboard. We've got our 200 algorithms, and we want to be tracking all of them and know, are they functioning within bounds or not? We want to look at measures of typical sort of ML ops approaches with accuracy, precision, drift, et cetera, but also fairness and equity and the effect that they're actually having. We need the bidirectionality built into this, and then we need to investigate the cause and take action when we see problems. We've done extensive user-centered design with a grant from the Gordon and Betty Moore Foundation to really build this out, and we now are in the process of extending it, and I'll talk about that. Just to show you a couple of mock-ups and screenshots, after a lot of iteration, essentially it looks something like this, where we've got the algorithms, and at the level of governance, at our committee, we can look at this at a glance and say, okay, are these, which ones are out of bounds? And if we see an error or we see a warning, then we can drill down more deeply and understand, is it a performance issue, or, is it an outcome issue? And that's really, really critical, is that what we are building into this is the actual outcomes of interest. So if it's a sepsis algorithm, we don't just want to know how it's performing statistically. We want to know whether or not it's actually affecting the identification and treatment of patients and ultimately morbidity and mortality. If it's a readmission prediction algorithm, we want to know that. And once we put this in place, the first one on there called Cornelius is actually a readmission prediction algorithm that we developed, that we trained, that we validated, and as soon as we started monitoring it, we figured out that it wasn't working. Now, everybody thought it was, but it turns out it had drifted considerably and we needed to adjust it. This is what it actually looks like in practice, and again, you can drill down and get more detail temporally if you make adjustments. Again, happy to talk about that, but I know we're low on time. The thing that's also been really key to the development of this is we've been building it with an eye to making sure that it could be used and deployed elsewhere. Because we also want to learn from the lessons of the past. Our challenges that we're facing today, a lot of them come from not having realized that or not having been deliberate about our electronic health record deployments and how it is that we could have done that better. So we want to learn from those lessons to say, how do we do better with AI? And some of that is going to be benefited not only from the local algorithmic vigilance platforms that can be used, but also from interoperability, if you will, or intersectionality between these. So what we want is to actually release this and have an open source collaborative. We're going to be extending this through our train network and through others, and we call this the VAMOS Collaborative, where we're going to bring groups together, and this is an invitation to anybody who's interested, to be part of continuing to build this out and use it locally. And then interconnect so we can develop evidence, build that, and actually continue to improve what we're doing as a group. So we're going to be expanding the use cases, we're inviting partners now, and then developing standards so that whether you're using this platform or another one, the most important thing to me is that we are standards-based so we can all learn from each other and benefit. So if you guys see a problem with an algorithm that we're using, we can benefit from that before our patients are harmed, and same for you, and all sorts of other use cases. Finally, the last lesson is that as informaticians, we must help. We need to support these activities along with our partners in health systems and in tech. We need effective AI for prevention, diagnosis, and treatment, and we need to make sure we deploy it in a way that's going to work to accelerate discovery and translation. We need this to overcome the health disparities that we know are rampant, and to empower people and systems to do better. And we need to create this virtuous cycle. And we need to do this with urgency. I started with my story. Again, it is not lost on me that, and it's not hyperbole to say that I'm probably standing here in front of you because luckily I went to medical school and I happen to remember that day where I learned about pheochromocytomas, and I was able to accelerate my own diagnosis. But that's not a system that we want, right? And that's not okay. So you and me and all of us need to work together to make this better, and I know we can. And if we know how to fix things, we need to fix them, and we need to work together to do it. And if we don't know, then we need to innovate. And I know that's what everybody's here to talk about. This picture is hanging in my office. It's the pheochromocytoma Hulk. It was drawn by Mike Natter, who's now an endocrinologist, actually working in New York. But before he went to medical school, Mike was an artist and still is an artist. And when he went to medical school, he would draw to remember what he was learning. I bought his first print. And he lets me use this in talks. And I am no longer a green rage monster. Thankfully, I am now just a mild-mannered scientist again. So thank you very much. I know I went a little over time, but I really appreciate it, and I'm happy to talk during the breaks. Yeah.